like to be on schedule so that people can finish on time and be at the airport. Thank you very much.
Thank you. That's 20 seconds gone from me. Okay, so why talk about psychosocial care? We've been
I'll give you
hearing about
that.
the pain discussion that we've had. Quality of life are areas of concern. We are talking about different cancers at different age. So prostate cancer patients compared to testicular cancer patients, different stage in life. What about prognosis? The treatment implications, we have to remember that, and the possibility of recurrence progression. And what do we have to see? We have to think about coping for both patients and caregivers and consequent mental health issues. So I'm going to stick to what the literature shows, and you can see and you can expect that depression and anxiety symptoms are really common in all the genitourinary malignancies, almost 40 to 60%, some more of depressive and anxiety disorders. But specifically in prostate cancer, it's seen that 60% of the patients, mainly older adults, have a lot of decision-making distress. And we know about depression and anxiety symptoms related to androgen deprivation therapy. We've seen that any kind of treatment, most patients really tolerate it well psychologically. There's been some studies showing that active surveillance will have, patients will have more anxiety, but that's sort of not it depends. And the cognitive impairment that is associated with prostate cancer, which some studies have shown, it still is at an equivocal evidence base now. For bladder cancer, we know, and it's proved that the suicide risk is really quite high, and it's mainly in older, unmarried, and those with advanced disease. And because of the significant mortality despite advances in treatment, there are poorer physical outcomes, and the quality of life impairment because of things like urinary complaints, sexual effect on sexuality, and most of the GU malignancies. That's a problem, that it's something about shame, and you can't really talk about them, and especially in countries like us. And kidney cancer, it's really about, again, mortality, the possible prognosis. So 20 to 30%, this is quite proved, about depression and anxiety and maybe disorders. And there's always that fear of cancer recurrence in the localized cases. Testicular and penile cancer, especially testicular cancers, it's all about coping with diagnosis and its stage in life. So it's all problems with intimacy, sexuality, fertility. We didn't really talk about that in the panel discussions, and this is so huge for them. And typically also body image, fear of recurrence, and long-term effects of treatment. So overall, what should we do about psychosocial interventions? We should think about early recognition. There's a whole big need for information because patients and caregivers need to make the right decision, which there is a role for active counseling. And at each transition point, how early is appropriate? It's at each transition point, we have to think of long-term effects, and we also have to think of the caregivers. What is the evidence base? Evidence base is mainly that there is a small and short-term benefit in certain domains of QOL and knowledge about, that is in prostate cancer patients. And in bladder cancer, there has been some role for group and couple interventions. So moving on to palliative care, because the reasons why we are talking about psychological health are the same things that we need to focus on palliative care. And those who think that palliative care is end-of-life care and it's hospice care, this is not. This slide shows that it is really encompassing along the cancer trajectory and the disease trajectory, and can begin right early and go on to when it is terminal decline and terminal, and of course post-bereavement. And ever since Jennifer Temel broke into the scene with studies on early palliative care, and now we have Cochrane review saying that early palliative care is so important. So unfortunately, in GU malignancies, the uptake for palliative care or the referral to palliative care, if you see retrospective studies, is not more than 10 to 20%. And in the established studies on early palliative care randomized controlled trial, GU malignancies have been represented in only maximum 8 to 10% of the patients. So these are some of the non-randomized studies of palliative and supportive care interventions. And you see that there are some short-term benefits, but the most of the things is the ones that you see here. There's no randomized control trial of integration of palliative care in GU malignancies as yet. These just show some trials in using exercise as a supportive intervention. So aren't there so many possibilities now? So you can, then these are some of the, where do we see? So is it early? Is it appropriate? Is it timely? We'll talk about that. But the things that we need to discuss are, decision making. How can we help with decision making? There is any time we can talk on emotional and spiritual issues, fear of recurrence, death anxiety, so that at any stage. Of course, there's physical symptoms and subsequent psychological distress because of that. There's always financial concerns, ethical, legal, and decision-making difficulties. And at any stage, again, it is difficulties in how best to use surrogate decision makers. So there are some movements from early palliative care to something called timely palliative care. Because how early is early? Nobody really says about how early is early. We say within 2 months or within 3 months. And it's been seen that early palliative care, those who were referred for that, some of them really didn't have that much of symptoms at the beginning. So they don't tend to follow up, or it is not that effective. So what they recommend is something called as timely palliative care with 4 components, which is you do a routine screening, you have referral criteria, we have automatic triggers, and this is mainly for outpatient palliative care resources, and this will help in increased timely palliative care access and improved patient outcomes. And so I leave with these thoughts for you. Should it be early? Should it be timely? It should definitely be a person-centered and a family-centered approach, both for psychological help as well as palliative care. It should be needs-based, those who need, but how do we know? We need to identify them. And of course, there's possibilities for integration, and in our resource constrained settings, we really need to develop our own models of service, both in psycho-oncology and palliative care. So thank you very much, and should I get a brownie point? I still have 2 minutes, okay. So that gives me time for questions. So.
Yes.
Thank you, Dr. Joyita. So, sometimes we see it on the face of the patients that the moment we mention about the need to visit the palliative clinic, they feel as if, there's not much can be done, even though the fact remains that we are still looking at like a 5-year or longer survivor. So this scenario could be either because the disease, even though metastatic, typically prostate, even in a advanced prostate cancer, some of these patients live 5 years more. Or it could be somebody with a non-advanced disease, but we feel the need to, see your department. So could there be a better or an alternative? Do you think that the acceptance of the palliation might be more if we dissociate the term palliative and use an alternative term for it?
Okay. So you've come to the nomenclature bit. However you dress it up, the underlying is the same. So there are studies which have said, MD Anderson Cancer Center has said, moved from palliative to supportive care. Some people are very staunch about maintaining palliative care, but I think it is the components which are important. Just changing the name, even if you talk about that, patients talk amongst themselves, and it is still going to be room number 75. whether we name it as palliative care or it is supportive care. And also very important to remember is a lot of the stigma that you're talking about comes from professionals themselves. And why do we do that? Is because we're equating palliative care equal to end-of-life care, palliative care equal to hospice care, which is no longer the case. It has moved up some leaps and bounds. So we need to, because these are subliminal messages which we are going to do. We can also do better from palliative medicine specialists. We can do leaflets, we can put up notices, we can do that. And it's good that we work together in Tata Hospital, so we don't have that. Patients will have that, and that's all over international. And some people are very staunch for supportive care, calling it supportive care. Some people sit on the fence and say palliative and supportive care, so you don't want to take sides. And some people will staunch about palliative care, and the last group includes me, because I don't really think that changing the name changes the service. We do the same thing, so that is there. So we need to do more, especially in our settings, but it's not just our settings. There is that bias about. And that's because it's always been about end of life. If we don't have that, if we have to talk about what we do, we talk about physical symptom management, psychological symptom management, help in communication, make goals of care decision, better decision making, advanced care planning. These are the components that we need to focus on. And this is what we need to advertise and publicize.
Thank you.
Oh, I had to ask the Madam Chairman to make sure I had time for this question. So great talk. I would say the nomenclature is not unique to India in terms of palliative care, supportive care, et cetera. I think we see it across the ocean. One question I do have is sort of how do you square away the patient panel we had yesterday and their concerns with access to just the physician, but at the same time we're trying to speak out of both sides of the same mouth of getting early access and early referral to, early intervention for understanding the disease and the palliative care, because it seems like we're torn not just here but across the world in terms of resources for both.
Yes. So resources are always going to be a problem. So I think that is why I left the last slide as that we need to develop our own models with the number of resources that we have. And the resources start right from the oncologist. So whatever the basic primary palliative care approach that the oncologist does goes a long way. And especially in a country like India, where doctor is God. Of course, we are also doctors, but the oncologist is Godder. So everything will be about that. So if we can pass on that message and we do that bit of symptom management, pain management, and then say, don't you think that you would be better off with, going to this particular service, provided that service is there. What if the service is not there? And that becomes a collective responsibility, that this is such an important, essential, crucial service. We should all buy in, all institutions, private sector, public sector, NGOs, we should all advocate for palliative care. That is one way to go about it. We can complain till the cows come home, but that is not going to be doing this. So we need to do our bit. Thank you.
Thank you, Dr. Jayita Devdhar, for an excellent talk. Our next speaker is Dr. Amandeep Singh Arora, who is an assistant professor in the Department of Uro-Oncology at Tata Memorial Hospital, Mumbai. He'll be elaborating on post-treatment quality of life and bladder cancer. Over to you, Dr. Amandeep. You've got 9 minutes. Thank you.
Yes, great. Good morning, everyone. After that absolutely amazing talk by Madam Devdhar, we'll look at post-treatment quality of life, so something a little earlier to the setting that Madam spoke about. So over the next 9 minutes, we'll go over these 3 settings that we see bladder cancer patients in. And for all of these, we'll look at what tools do we have to assess QOL. Do we have Indian data about it? Is there scope for improvement on our parts to improve the QOL for our patients? And what numbers do we actually quote to our patients while counseling them about side effects and long-term side effects? Why actually are we discussing this? Professor Ian Tannock in this very hall said that all our efforts, all studies, either have to make patients live longer or make them live better. So this talk is about trying to make them live better. With intravesical therapy or cystectomy or with radiation, survival benefit has reached a plateau, right? So you do cystectomy, patient is going to live long depending upon what biology the patient has. Only systemic therapy advancements can push the line further. Only they can, increase overall survival by a few months or a few years now. So we need to make our established existing treatments more tolerable. That's all. We need to just make them a little more tolerable for our patients because we cannot increase lifespan further with our surgical treatments. And we maintain long-term quality of life for them. What aspects of QOL do we look at? We want to look at overall QOL, that is very vague. So we break it down into physical, psychological, and sexual QOL. At what time points? So we assess at baseline because that is how we compare in the future. Immediate is for BCG on when the patient is on installation, cystectomy when the patient is in the hospital with you and during RT. This is usually captured in literature as post-operative morbidity and not really quality of life. And then actual quality of life is reported at 3 months, 6 months, and 12 months, usually in literature. Coming to NMIBC with BCG, so why is QOL important in the NMIBC setting? Because NMIBC doesn't kill, right? Patients live long. We have long-term survivors, and many of our patients are young and they're expecting to live as normally as they were earlier. How do we measure QOL in them? So this is a little heavy slide. So we have cancer-specific questionnaires. I'm not going to go into the details. I'm only naming them. EORTC QOL Core 30 is the most commonly used in literature. The FACT with 27 questions is also used. We have disease-specific. So we come to bladder cancer-specific questionnaires. These are the 3. So you can see they are all in excess of 20-25 questions. So they are objective, they are validated, they're great for research, and they help you compare across papers. One thing that we don't know is if for function X, if open cystectomy has a score of 80 and robotic cystectomy has a score of 85, and that is statistically significant in that paper, is it actually clinically significant? That nobody knows. And you obviously cannot be using these questionnaires in your day-to-day practice in the OPD. So what do you do in the clinic? You use the CTCAC for urinary symptoms and hematuria. You use the International Prostate Symptom Score, although it is for BPH, but you use it to assess urinary symptoms in our patients. And we use the IEEF-5 for asking a patient 5 questions about sexual health. That is also mostly male patients. Do we have Indian data about QOL and NMIBC? So this was from the group at Kokila-Ben. And we look at only this column because it is about the Moscow strain, which is available in India right now. And you can see